reality is that in medical school, they don't really teach doctors how to prescribe medications, despite the fact that's all the hell they do, is prescribe medications. Why isn't this working? Anyway, so they don't prescribe medication, or they don't teach them this stuff. And the reason they don't teach them this stuff is because the pharmaceutical companies come around and they tell them, they give them all this information, and they try to, they use propaganda. In the old days, they used to give them stuff. They gave them really nice pens, or they gave them a laptop, or they gave them an iPad or whatever. You think I'm kidding, but these pharmaceutical companies want them to prescribe their medication. And some of these medications are god-awful expensive. I mean, just worse than you could possibly imagine, and I don't understand why this isn't working. Why? This is the last lecture. Come on. Why in the world? Oh, do I not have it turned? Maybe I don't have it plugged in right. Maybe it's me. Maybe I've done. Yeah, there it is. Okay, here we go. That was it. All right. Anyway, so the doctors aren't really getting very good information, or they're getting great information because all these pharmaceutical reps wander around. Now the weird part is, I guess this isn't that weird. I don't know if you understand the whole thing between boys and girls, but most doctors are male, and most reps are either really cool guys or they're really attractive women in really small outfits. It's just the most bizarre thing in the world. I worked in medicine for 30 years, and I was always surprised who was coming in the door and how tight her skirt was. Really, really weird stuff. I know, it's shocking, isn't it? They're using sex to sell drugs. If you watch Big Bang, Penny, of course, this very attractive woman who everybody is madly in love with, becomes a pharmaceutical rep, and now she's one of the best pharmaceutical reps at her company, which doesn't actually exist if you look at that company. Anyway, but it's true. That's the way the world works. So they were giving these doctors all kinds of stuff. They were flying them to Hawaii and talking about all these medications. They're giving them free vacations and that kind of stuff, just to get them to prescribe their medications. So they don't really teach this stuff in medical school, not very well, certainly not very well. They may have one class in pharmaceuticals. So we're going to talk about it today. The only reason that I know about it is because, I've worked in this field for an extended length of time. I've talked to a lot of pharmaceutical reps. Sounds like I was flirting with the young lady with a tight skirt on, but the reality is there were a bunch of guys, and the females wouldn't talk to me, so it didn't do them any good. I couldn't prescribe medications. So it was only the guys that would talk to me, as weird as that is. The first thing we're going to talk about is selective serotonin reuptake inhibitors. These are really important. Depression is the second most common problem certainly in the United States. Depression is. How do SSRIs work? They inhibit serotonin reuptake, so they increase the synaptic serotonin levels. That's fairly obvious. We talk about this over and over again. Many selective serotonin reuptake inhibitors affect other receptors, especially at high doses, and this is one of the problems. There are side effects to the SSRIs. The clinical effect usually takes weeks, so mechanisms go beyond simply increasing synaptic serotonin level. If they give you Prozac today, then you may feel better right away. But of course, that's the placebo effect. You may feel better right away, but you won't reach a therapeutic level for about 4 to 6 weeks, in essence. So despite the fact we're treating you today, and you're going to start taking relatively high doses of Prozac, it won't start working for about 4 weeks. It shouldn't start working for about 4 weeks. But if you've ever taken an aspirin because you had a headache, your headache went away almost right away, despite the fact that the aspirin was still wandering its way down your esophagus into your stomach, hadn't digested yet. It's got a coating on it because aspirin is toxic. Is very caustic to your stomach lining. So there's a covering on the aspirin. It takes you about 20 minutes to digest it. and it can't get into your system for at least 20 minutes. But your headache went away as soon as you took the aspirin. Same way with Prozac. You start taking Prozac today, the placebo effect will kick in, and of course you'll start feeling better. There are several serotonin receptor subtypes. Serotonin receptors are located throughout the body, but they're especially in the GI tract, as odd as that may seem. So our depression, we're going to cure our depression with our guts. They inhibit serotonin. Indications in off-label uses, and this, like I said, this is a medical school lecture, and for this reason, doctors like to talk about giving somebody a drug for a really strange reason. And so this is off-label uses. All except Luvox, the FDA is approved to treat depression. Luvox is an SSRI that is not used to treat depression, as weird as that may seem. Various class members are also approved to treat generalized anxiety disorder. So if you have anxiety, potentially they will give you Prozac, Paxil, Zoloft, Effexor. They'll give you one of the SSRIs. You can use it to treat OCD. You can use it for panic disorder. You can use it for PTSD. But specifically, there is one specific SSRI that they use for PTSD. It's Desiril or Trazodone is the one they use for PTSD. We use it for eating disorders. The idea is if you have anorexia, of course, then you have a really serious problem with self-esteem. So we're going to raise your serotonin level, and hopefully that will cure your problems. Premenstrual dysphoric disorder is, we used to call it, what did we used to call that? Premenstrual syndrome, that's what we used to call it. Social anxiety disorder. So you can use the SSRIs to treat anxiety as well. Off-label uses, ADHD is another thing that we can use it for. Insomnia puts you to sleep. It actually dulls your senses, which sometimes will knock you out. Chronic pain syndrome. One of the things that SSRIs do, it allows you to relax, and if you relax, then potentially some of the pain will dissipate. Seasonal affective disorder, of course, that is not for people in Arizona, but seasonal affective disorder is very common in Canada, in the upper tier states, Montana, North Dakota, Minnesota, Washington State, Maine, those types of areas. Behavioral problems in individuals with dementia and intellectual disability, so individuals who have an intellectual disability, or with individuals who are older and they're having problems remembering things. And sometimes these people have really erratic behavior. Sometimes they become violent. I've been attacked by people with Alzheimer's disease before, which seems a little interesting. Being attacked by some old fart. That's okay. She didn't kill me, but she did throw a television at me. She missed me. Thank you.
I got a television thrown
Is that right? Was it by somebody with Alzheimer's disease?
It was somebody with schizophrenia.
Okay. The half-life of the SSRIs, there are some SSRIs with a short half-life, which means they clear your system fairly quickly. Paxil and Luvox, if you miss a dose, then the individual may have problems. Moderate half-life, Zoloft, Celexa, and Lexapro. And then Prozac stays in your system for a really long time. So it takes a long time to clear it out of your system, oddly enough. This is something that you need to remember if you have relatives that are taking any of these SSRIs. If they miss a dose, if it's Paxil or Luvox, they may be in trouble. But if it's Prozac, you can miss all the doses. Well, you can't miss all the doses you want. But if you miss a couple doses, it's not going to hurt you because it stays in your system for an extended length of time. Just a little bit of information about that. Side effects of the SSRIs, decreased sex drive and impaired sexual function tend not to resolve with time. In other words, once you start taking this stuff and you start having sexual problems, it's permanent, relatively permanent. The impotence is not going to go away. Sometimes it causes nausea, diarrhea, anorexia, and vomiting with individuals. This has to do with increasing the dosage. And sometimes it'll go away and sometimes it won't, unfortunately. If you take Paxil, there's a problem with weight gain. With Paxil you also have potential diarrhea and nausea. Headache, dizziness, and anxiety, especially with Paxil. A rash, insomnia, sedation, sweating, vivid dreams, tremor, dry mouth, especially with Paxil again, and bruising and increased prolactin levels in your system. So you can see the side effects for SSRIs are not insignificant. You can have some really serious problems. Especially the sex drive thing, people really don't like that. The rest of this they usually just put up with. The sex drive they really complain a lot about. And this is relatively permanent, and that's really the sad thing about SSRIs is that people don't like it because of the sexual side effects. Other drug interactions: Luvox, Prozac, Paxil, Zoloft, Celexa, Lexapro. They interact. You can't take them together. You have to either take one or the other, but you can't take any two together. There are drug interactions. Zoloft is what we give to mothers who are suffering from postpartum depression. Zoloft seems to work. It doesn't get into the milk, the mother's milk. She has less side effects, and that's what we treat women with postpartum depression. SSRI levels tend not to be altered by other drugs, but they can potentially increase levels and inhibit metabolism of certain drugs. And for that reason, you have to be really careful as to what you're giving somebody with your SSRIs. Because monoamine oxidase inhibitors, of course, you can't mix your antidepressants. If you try to do that, then you're going to have serious side effects. Unfortunately, if the person is, a lot of times what we see is, especially with bipolar disorder, we'll see an individual being treated with medication for their bipolar disorder, and then they try to juice up they seem depressed. So they try to juice up they try to lower their depression level by giving them an SSRI. Well, this works with some of them, but it doesn't work with others. Some things you can't mix. Paxil you can't mix with risperidol. Risperidol is an antipsychotic medication. Prozac you can't mix with meprobamate. Meprobamate is an anti-anxiety medication. Luvox you can't mix with Zyprexa. Zyprexa is also an anti-anxiety medication. There is increased suicidal ideations and increased suicide risk, especially with children early in treatment, but there is significant debate about the dangers of SSRIs. When Prozac first came out, of course, they gave it to like everybody and their cousin. Well, sometimes their cousins were killing themselves. They were committing suicide. So they decided they couldn't give it to anybody under the age of 18. That usually is the indication, especially with Prozac. Remember, Prozac stays in your system longer than any of the other SSRIs. So this is something that we try to maintain. We try not to give anybody under the age of 18 an antidepressant, but if we do, it ain't Prozac, it's something else. When Prozac first came out, they said 90 to 95% efficacy. Now it's in the 70 to 75%. We found lots and lots of people that it doesn't work on. So we've tried other things, we've tried other combinations of drugs, and they seem to be working better than Prozac. Prozac is like, when birth control pills first came out, they increased the woman's estrogen level, and we had all kinds of side effects. Well, that's what happened with Prozac. So then they came up with Paxil, then they came up with Zoloft, then Effexor, then Luvox, and then we got a ton of different antidepressants, SSRIs. And what we discovered was Prozac wasn't the best. Prozac was the strongest, that was the problem. It was the strongest one, and it stays in your system longer than just about anything else. Serotonin syndrome is where you add SSRIs with monoamine oxidase inhibitors. Maybe lithium, if it's in the mix, then we have really serious can potentially have a really serious problem. This is one of the reasons why the doctors have to really monitor these individuals. Now the problem is if somebody is depressed, a lot of times they won't come in until they've been depressed for a year, for 2 years. So these are not people that like to go to doctors. Obviously, they're not people that like to go to doctors. So the doctor has to make contact with the patient. The patient won't make contact with the doctor. A lot of patients assume the doctors know what they're talking about. Doctors assume that everybody's exactly the same. So these individuals, the doctor has to reach out to make sure they're not having any of these horrible side effects. Diarrhea, tremors, sweating, restlessness, hyperreflexia. These are some of the negative things that can happen to these individuals. And they won't call the doctor, that's the problem. They assume that the problem's going to go away. What has to happen is the doctor has to reach out to the patient. There is a progression of symptoms. If untreated, the individual will become relatively psychotic. They will drift into psychosis. They'll become disoriented. They will have fever and rigidity. They'll go into comas. They'll start having seizures. And of course, if the SSRI syndrome continues, about 10% of them die. And it's not because, well, it is because of the symptoms, but the real problem is that the patient will not communicate with the doctor. That's the real problem. And this is the reason why the doctor has to reach out to the patient. If they don't, then they're not going to communicate at all. The patient will just end up dead one day because of the medication that they're taking. And of course, nobody called anybody because these patients don't want to call anybody. There are many medication substances that have serotonin activity. Dextromethorphan makes you happy. That's the stuff that's in cough syrup. That's the stuff that the cool people drink so that they can have a good time at the bar and the dance club or whatever. Dextromethorphan, fentanyl, of course. You don't want to mix your fentanyl with SSRIs. Fentanyl, one of the reasons people take fentanyl is because it makes you feel better. Demerol, of course, is an opiate, just like fentanyl is an opioid, I'm sorry. Just like fentanyl is an opioid. Sumatriptan, Alsuma, I don't know what this stuff is. St. John's wort, of course, is the herbal antidepressant. Does it work? Europeans use it. They don't use Prozac, they don't use Paxil or Zoloft, they use St. John's wort. So if you get depressed and you go to a German doctor, he'll prescribe St. John's wort, which you can buy right off the rack. I mean, it's not, you can buy it right off the, right out of the store. MDMA, of course, ecstasy increases your serotonin level a great deal. If you're taking Prozac or Paxil, you certainly don't want to take MDMA. LSD, of course, increases your serotonin as well. So there's a lot of things that make you feel good. There's a lot of feel-good drugs out there, including cough syrup. So knock yourself out. Fluoxetine or Prozac has a very long half-life. This is the one with the longest half-life, of course. It has significant drug-to-drug interactions, so you have to be really careful what you're taking with, including herbal medications. This morning I took a handful of drugs, man. Okay, I'm cool. I took DHEA, I took ginseng, I took ginkgo biloba, what else did I take? L-carnitine to increase the blood flow in my brain. It's an herbal. Does it work? Hell no, it probably doesn't do anything. I'm probably pissing it all out or something. Anyway, so it has significant drug-to-drug interaction. But I didn't take any Prozac, okay? So I'm probably okay. And of course, it can be activating. You've got to be very careful as to what you take with it. Celexa, we see this stuff on television all the time. It has few drug-to-drug interactions, and for that reason, they suggest that you add Celexa to your antidepressant regimen. Because it doesn't have, you can take it with Prozac, you can take it with just about anything. Effexor, you can take it with anti-anxiety medications. Has a high serotonin specificity. It does raise your serotonin level. It's typical or less, it has fewer side effects than Celexa does. And for that reason, they suggest that you mix your drugs. Lexapro, Lexapro is very similar to Celexa. It has very few drug interactions. It's a fairly simple dosage. There's only two sizes of pills, so it's fairly easy to use. Luvox is used for OCD. People with OCD, people who have to clean their house before they can do anything else. What is Maurice does that? Poor Maurice. So I went over to his house the other day, and he was cleaning his house so that he could start grading. I was going, what? I don't understand. Like, he's funny. You don't expect to see a guy, cleaning the house and washing the toilet, scrubbing the toilet. But he's sweeping everything up. He's got all the dishes are all washed. They're not just washed, but he's dried them off and he's put them in the cabinet. I mean, he's not going to let them drip dry. He's so funny. He's such a nice guy. He's a funny guy. Multiple significant drug-to-drug interactions with Luvox, so you need to be careful. Paxil is the second tier antidepressant. Prozac is number 1. Paxil is number 2. Zoloft, of course, is, as I said before, is what we use for women with postpartum depression. Paxil has significant drug-to-drug interactions, so you have to be careful, just like with Prozac. There are some reports of associated weight gain, and for that reason there are a lot of individuals that hate this stuff because it makes them paunchy. They really hate it. You can't miss a dose with Paxil. You will start having withdrawal symptoms, and that's Paxil. Zoloft, of course, has a multi-step dosing, and that's one of the reasons why they use it with women with postpartum depression. They'll start off low and they'll go high, as it were. They'll increase it until their depression goes away. A lot of postpartum depression has to do with hormonal levels. Paxil or Zoloft doesn't interfere with hormonal levels, but it's easy to dose, and for that reason they can find the level which gives the woman or dissipates her postpartum depression. So they use Zoloft. The newer antidepressants that are not less serotonin specific or affect serotonin differently than SSRIs. In 1981, now you have to remember the Prozac came out in the 70s. They started using it in the 80s and maybe the 90s, depending on where you were. So all of these things were brand new at the time. The first one was Desiril. Desiril came out right after Vietnam. Vietnam ended in '75. They were having a lot of problems with the guys coming back from Vietnam. They were suffering from PTSD. The federal government wouldn't diagnose PTSD until '85. So for 10 years, these guys were suffering with something. They were beating up and killing their wives. They were getting into fights. They had 1 out of every 2 combat soldiers coming back from Vietnam ended up in jail for one reason or another. Usually it had to do with assault. It's not like they were all stealing things. It was they were in jail for assault or murder, as strange as that may seem. So it took them a long time. I mean, so 1 out of every 2. We're talking about 8 million men. Okay. We're talking about 8 million men were in country in Vietnam. We're probably talking about between 3 and 4 million men who were in combat during Vietnam. So we're talking about a lot of people ending up in jail. A lot of divorces, a lot of men came back, and of course they couldn't handle it. So the first antidepressant that they came up with was one to treat PTSD. And it was Desiril or Trazodone. And the reason it worked was because it decreased your level 4 deep sleep. It made you jump right into REM sleep. And for that reason, what the problem was, these individuals were having recurring dreams about combat. When you have those types of dreams in level 4 sleep, in stage 4 sleep. So what they did, they came up with Desiril, and Desiril is an antidepressant that makes you jump over your stage 4 sleep, your first round of stage 4 sleep. You'll go into stage 4 sleep later on, but it's the first one that was really causing the trouble. So they came up with Desiril or Trazodone in 1981 to treat individuals suffering from PTSD. In 1985, the federal government finally realized that, geez, we've just incarcerated, 2 million combat veterans from Vietnam. Maybe we ought to talk about this and see what we can do about it. So in 1985, they said, oh yeah, they've got PTSD. And at that point, the VA was able to treat them for PTSD until they came up with a disease, until they came up with a problem, they couldn't treat them. So they came in with all these symptoms and they said, well, we don't have a disease to fit that. We can't give you a qualification. I'm sorry, you don't have any problems. You just have these individual problems, and maybe they existed before you went to combat. So it doesn't have anything to do with the federal government. So it wasn't until 1985 that they started giving these guys any disability for their PTSD. Anyway, 1989, Wellbutrin was developed. 1993, Effexor was developed. Effexor, as we're going to see, is not only raises your serotonin level, but it also raises your norepinephrine level. In 1994, Nefazone was developed. 1996, Remeron was developed. 2004, Cerazone was discontinued, although there are generics out there. Cerazone, of course, is relatively dangerous. You've probably heard of Cymbalta. They advertise it on television. And this is another antidepressant that they want you to take with your antidepressant. Effexor and Cymbalta are both serotonin and norepinephrine reuptake inhibitors. This makes a lot of sense. If we raise your serotonin level, it makes you feel happier, but it doesn't make you feel good. But if we raise your norepinephrine level, it makes you feel like you're on top of the world. It makes you feel like you can conquer the world. So Cymbalta and Effexor make a whole lot of sense. We're raising your norepinephrine level and making you feel like you're functional, like you can do something. Just raising your serotonin level doesn't always do that. It just makes you feel happier. And it's the reason that people eat pizza and feel good about eating pizza. As long as there's cheese on your pizza, it's raising your tryptophan level. Tryptophan, of course, is a precursor for serotonin. So the more fat you eat, the more pizza that you eat, the more cheese you take in, the higher your serotonin level, and the better you feel. Mirtazapine or Remeron has serotonin subtype and norepinephrine activity. Trazodone, of course, affects a different serotonin. It has a different receptor site, and for that reason, Desiril is more. They just take it at night, just before they go to bed, and it makes them jump over, like I said, stage 4 sleep. Wellbutrin has dopamine and norepinephrine activity. For this reason, some people take Wellbutrin rather than Prozac or Paxil or Zoloft because Wellbutrin has no sexual side effects. It doesn't raise your serotonin level. Why does serotonin do this to you? Why does it change your sexual response? The reason is because your testosterone level is your sex drive. It's the testosterone in your hypothalamus. The way we control your testosterone level in your hypothalamus is with serotonin. So if we increase your serotonin in your brain, it also increases the serotonin in your hypothalamus, and potentially you'll have sexual side effects because the serotonin dissipates the effect of the testosterone. So all of a sudden you start having sexual side effects to taking an antidepressant, one of these antidepressants anyway. These are the atypical antidepressants. Some of the off-label uses, they are all approved to treat depression, so we can use anything on this list to treat depression. They are the atypical antidepressants. SNRIs have been shown to be effective in chronic neuropathic pain. These are individuals that are suffering from, geez, I was going to look that up too, wasn't I? What is that pain, that type of pain? People, it has to do with overreactive nerves. I can't think of the name of it. Anyway, this is the neuropathic pain we're talking about. People with chronic fatigue syndrome also have this type of problem. We treat them with SNRIs as well. Nicotine addiction. SNRIs are used to augment the SSRIs. They reduce the SSRI sexual side effects because, of course, it doesn't raise your serotonin that much. It actually raises your norepinephrine level at the same time. Trazodone, of course, the Desiril is what we use for insomnia. These individuals don't want to fall asleep. What was happening with the Vietnam vets that were coming back, how in the world are they treating their PTSD that doesn't exist because it didn't exist until 1985 when the VA finally decided that it did exist. So how did they treat it? They treated it with drugs and alcohol. So these guys were getting drunk. They were getting fall down drunk so that when they went to sleep, they wouldn't have these intrusive dreams. But if you take the trazodone, it makes you jump over that dream. So anyway, so they use it to treat insomnia. There are many similar uses to SSRIs. So anything that you use an SSRI with, you can use an SNRI. If any of you have depressive symptoms, then I would suggest not using Prozac or Paxil or Zoloft. I would suggest using one of these SNRIs. Maybe Effexor, well, it all depends on what your problem is. And most of these are not associated with sexual dysfunction. Like I said, the vast majority of people who are taking the SSRIs, their biggest complaint has to do with the sexual side effects, the sexual dysfunction. Effexor is similar to the tricyclics with less safety and side effect concerns. Effexor is what my wife was taking. When I went on my Fulbright trip to South America, I was gone for 6 weeks. It was in the summertime. She got depressed, and the doctor gave, and she was perimenopausal, so the doctor gave her Effexor. It's an SNRI. It's an SNRI. So it made her happier anyway. Eventually, she weaned herself off of the stuff. The FDA has approval for depression and generalized anxiety disorder and social anxiety disorder. Her problem was more anxiety than depression. She was living, where was she? Oh, she was in the middle of Montana, living by herself. It's dark at night. The whole thing, whole 9 yards. If I was there, she would be okay. I like it when it's dark because I can see really well in the dark. So if somebody tries to sneak up on me, I'm like a dog. I can see them, or a cat. And they're wandering around trying to find something, and I'm looking at them and watching them. Anyway, but my wife doesn't have that same ability to see in the dark. SNRI activity depends on dose. There are minimal drug interactions. The side effects, there are side effects with missed doses of Effexor. It has a short half-life, so if you miss a dose, then potentially you start having nausea and vomiting. This happened to my wife. She forgot her Effexor. She went off on to a conference. It was a 3-day conference. She forgot her Effexor, so she figured, well, what the hell? I'll wait until I get back to start taking it. The second day of the conference, she started having diarrhea, vomiting, and headaches. And of course, she thought she was coming down with the flu. There was another lady that she was rooming with, and the lady said, that sounds like you missed a dose of Effexor. So she gave her one of her Effexors, and she was fine. So she missed a dose, and she started having problems. Cymbalta is an SNRI profile, minimally dose-dependent Cymbalta, and this is one of the reasons why they They suggest that you add it to your antidepressant regimen. It's indicated for depression and chronic neuropathic pain once again. So we're using the SNRIs to treat neuropathic pain. Wellbutrin or Zyban raises your dopamine level. It's a dopamine reuptake inhibitor. Zyban is, of course, used for treating people that are trying to get off of smoking. Why does it work? Because it raises your dopamine level. A lot of people smoke because when you puff on the cigarette, the nicotine, you get a nicotine spike, which gives you a dopamine spike. So people smoke because it makes them feel good. But if you take Zyban, of course, you get the dopamine spike without the nicotine. There's a seizure risk in certain patients. It all depends on who you are. Turns out that it has to do with race and ethnicity. Select individuals react very poorly to Zyban. Those individuals are African Americans. What's the difference between African Americans and everybody else? Something biochemical. African Americans are more susceptible to sulfa drugs as well. Sulfa drugs will give them, not only will it damage their liver, but it will shut their liver down. So you can't give sulfa drugs to African Americans. So there are biochemical differences between us, despite the fact that we're so very close as far as our DNA is concerned. There's a potential drug interaction that is often significant, and that's with MAOIs. You should never take an MAOI with anything else. MAOIs, okay. Monoamine oxidase inhibitors. And we're going to talk about monoamine oxidase inhibitors in just a second. Remeron is complex serotonin and histamine, has complex serotonin histamine activity. Receptor activity changes with changes in dose, sedation and weight gain, especially at lower doses. That's with the Remeron. There are causes lipid abnormalities, which is a problem, can potentially be a problem. And of course, it has drug interactions are very minimal, except with "you're leaving me."
Yeah, they told me to do an invocation. Administrators told me to do an invocation at the library.
Well, good luck. I hope everything turns out okay. Don't mention my name, okay? We're praying for everybody, especially Bradway, who's all, well, I'm not going to use the F word, but we'll say screwed up. Okay, there we go.
I'll come see you later today.
Okay. Oh, I'm not going to be here. I'm not going to be back until Tuesday.
Okay.
Okay, because I have to fly to Albuquerque, or have to fly to Albuquerque so I can fly out of Albuquerque. I'm driving to Albuquerque. Okay, we'll see you. My son's graduating from college, so I'm really excited. Cerazone is rarely used due to irreversible liver toxicity. It's pulled from the market by its manufacturer in 2004. But guess what? There are some generics out there that is made up of this stuff. I almost said shit, I'm sorry. It's still popular with some patients. It really works. But there are some toxicities with select individuals. Once again, there are certain ethnicities, racial and ethnic groups, they can't take this stuff. In this case, it's African Americans who can't take it. Desiril, of course, we've already talked about it. It quiets you down. It causes weight gain, which the Vietnam vets didn't like. It lowers your blood pressure. And a lot of these individuals started taking Desiril, and it probably saved their life because they had high blood pressure anyway, especially the African Americans who were taking this stuff. It's most commonly used for insomnia, but of course it's not supposed to be used for insomnia. That's off-label. There are rare instances where it causes painful erection. This is known as priapism. And of course, if you don't treat priapism, priapism is where you have an erection that won't go away. That's what priapism is. And sometimes the Desiril will cause that problem. How can I explain this? Males will have, will go through, it's like a checklist. It's like when you get on an airplane, the pilot has to check everything to make sure the flaps are working. That's the way things work. Well, humans have the same thing. We have a checklist, especially males. So males will have spontaneous erections, usually when they're asleep, strangely enough. Now the problem with priapism is that it gets stuck. They get stuck. So they'll have spontaneous erection and it won't go away. This can be a really serious problem. We noticed this with individuals taking Desiril, and of course they were waking up with an erection, and the erection wasn't going away. And for that reason, of course, they had no idea how long they'd had it. This is only, like once again, it's only with select individuals, and those are African Americans again. Tricyclic antidepressants, tricyclics and monoamine oxidase inhibitors were the first antidepressants that were developed. Tricyclics didn't come around until 1958. They developed this stuff as an antipsychotic. It didn't work as an antipsychotic, but they discovered that it worked as an antidepressant. So in 1958, they started giving people this stuff. Prozac, of course, didn't come around until the 1980s. So if somebody was really depressed and we were trying to treat them for it, they might take tricyclics or monoamine oxidase inhibitors. Now the odd thing is that these tricyclics and monoamine oxidase inhibitors were discovered at the same time in 1958. But as we're going to see, monoamine oxidase inhibitors have these amazing side effects that are fairly devastating. So it was the tricyclics that people were taking. Now the problem with the tricyclics is that it's toxic to your liver. So if somebody's taking a tricyclic, we have to check their liver monthly to make sure they're not having any negative interactions. We gave this stuff to kids. The first time I ever drew an imipramine level was on a 13-year-old boy. This is when I was in the service. I drew blood on this kid, and we did an imipramine level. Of course, I was in the service in the 70s, and that was before Prozac or Zoloft or any of the other SSRIs were invented. So we were treating everybody with severe depression. We were treating them with either monoamine oxidase inhibitors or tricyclics. In the 1960s, imipramine was the first tricyclic that they developed. Then in the 1960s, they developed other tricyclics, nortriptyline. All the amines were tricyclics. 1990s, significant reduction in use due to introduction of SSRIs. Of course, the SSRIs were developed in the 1980s, and they were approved by the FDA in the 1990s. SSRIs, of course, had fewer side effects. You could take it without worrying about it. It wasn't toxic to your liver, so people started taking the SSRIs instead of the tricyclics. The mechanism of action, it raises your norepinephrine level, raises your serotonin level. Actually, it raises your histamine level as well. It works on your muscarinic and the alpha adrenergic receptors. Anticholinergic activity leads to many of the side effects of these drugs, and of course that is the problem with the tricyclics. There's just too many side effects. Depression, it's used for depression and similar spectrum disorders, just like SSRIs. It's especially helpful with chronic pain and depression, secondary to medical conditions such as AIDS. Of course, AIDS didn't come around until the 80s, so we really weren't treating people with tricyclics until we realized that SSRIs weren't working on these guys. So they started giving them tricyclics, and it actually worked. Enuresis, narcolepsy, premature ejaculation, insomnia, migraine, prophylaxis. These are the things that we use it for. We use it for individuals that have a problem with controlling their urinary flow, people with narcolepsy, people with premature ejaculation, as it says, and migraine headaches. Drug interactions, multiple significant interactions in each direction with potentially serious consequences, and for this reason, if somebody's taking tricyclics, we try not to give them anything else. You never know what the side effects or what the drug interactions are going to be. Side effects: dry mouth, constipation, blurred vision, and urinary retention. Remember, we were treating people that couldn't control their urinary flow. One of the side effects is that it makes you retain urine. When we say retain urine, we're not just talking about your bladder gets full and you can't empty it. We're also talking about you have more fluid in your system, so you feel bloated a lot. And this is one of the problems with tricyclics. The people felt bloated. Women especially didn't like it, especially women who had premenstrual syndrome, where they became bloated with their menstrual cycle. They didn't like this stuff. It was mostly used for men because the women didn't want to take it. There's a problem with cardiac arrhythmias and conduction changes. So if you have a heart problem, this can potentially kick you into a heart attack. Orthostatic hypotension. Orthostatic hypotension is passing out when you stand up. So your blood pressure would go down when you stood up. So you're okay sitting down. As soon as you stand up, you pass out. Sedation, weight gain was another problem, but then again, we talked about the urinary retention. So you were collecting or you're holding your liquid into your body. Cautions: overdose is frequently fatal. Tricyclic, so you can overdose on this stuff. SSRIs, it's really hard to overdose on SSRIs. Some of these drugs that you can take, really hard to overdose on. Aspirin, of course, will burn a hole in your stomach and kill you. So you can kill yourself with acetaminophen, which is toxic to your liver. But the tricyclics, if you take an extra pill, then you might not wake up the next morning. Patients with bipolar disorder may be pushed into mania or rapid cycling with tricyclics. So it's not something that you would give to an individual with bipolar disorder. We were trying to find an antidepressant that we could give people with bipolar disorder because we were controlling their bipolar disorder. They weren't cycling as much as they were before, and everything was leveling out, but they were depressed. So we're trying to find something that we could give them with lithium or with the anticonvulsants, so that we could make them seem like happier people, as strange as that may seem. It didn't work with the tricyclics, certainly didn't work with the monoamine oxidase inhibitors. It didn't work. We couldn't give them any antidepressants until we developed the SSRIs. And then we could give them Prozac with their lithium. We could give them Prozac with their carbamazepine or whatever their anticonvulsants were. Monoamine oxidase inhibitors were actually discovered in 1952. They were looking for an anti-tuberculosis drug, and they found something that actually worked on depression. So monoamine oxidase inhibitors were kind of the first antidepressant, but they didn't really treat people very often because they couldn't figure out the dosage. Then in the late 50s, they started giving people monoamine oxidase inhibitors as an antidepressant. They'd figured out the dosage. By the time they discovered tricyclics, they had started using the monoamine oxidase inhibitor as an antidepressant. 1962, we realized, oh my God, this guy ate a hot dog and now he's dead because he was taking his monoamine oxidase inhibitors. Do you think I'm kidding? First guy that died with the tyramine overdose was a guy that ate a hot dog. Then they discovered there's a lot of things you can't eat if you take monoamine oxidase inhibitors. And that was in 1962. In the 60s, they came up with the strict dietary restrictions. You can't eat anything fermented, anything that is processed like cheese. So if you take monoamine oxidase inhibitors, you can't eat cheese, you can't eat jerky, you can't eat hot dogs, you can't eat sausage, you can't drink wine, you can't drink beer, you can't eat olives because they sit on the shelf. Anything that sits there and is treated with tyramine so that it can sit on the shelf for an extended length of time, you can't eat. So, I mean, this limited people as to what they could eat, but it's really serious. 1960s, significant reduction in use due to introduction of tricyclics. So we started treating people with tricycles. But remember, tricycles have a problem as well. Their side effect is that it's very toxic to your liver. So if you take tricyclics, you can't take acetaminophen, you can't take Tylenol, because acetaminophen is toxic to your liver as well. And guess what else you can't drink? Alcohol, because it's toxic to your liver as well. Transdermal, in 2006, they came up with IMSAM, which is a transdermal patch, which is kind of exciting, if you think about it. Monoamine oxidase inhibitors, effective antidepressant for those who can adhere to the necessary restrictions and tolerate many of the other side effects. If you take monoamine oxidase inhibitors, you can't take anything else. And you have to be really careful as to what you eat. You have to ask people what is in the food at Taco Bell, because you need to make sure that there's no processed meat in the taco. You just can't sit down and eat something. You can't even eat a salad, because there may be something in the balsamic vinegar that they can't eat vinegar or drink vinegar. So there's just a ton of restrictions. Very long duration, requiring caution when mixing with restricted substances or medications. It's not like you can't eat any of this stuff. It's that at some point it's going to tip over and you're going to have a reaction. Cheese, chocolate, soybeans, hot dogs, dry sausage, caffeine. You can't drink Mountain Dew. I know that would destroy me if I couldn't have my Mountain Dew. Beer, wine, pickles. You can't eat any pickles. You know those dill potato chips? I love those things. Anyway, you can't eat those because it's got dill in it, no olives. Drug-to-drug interactions, there's just a ton of them. There's multiple prescribed and over-the-counter medications can be potentially lethal, so you have to stay away from everything. Remember that dextromethorphan you're using to control your cough? You can't use it with this stuff. And serotonin syndrome is very common with monoamine oxidase inhibitors. It's available in different formulations, Nardil, Marplan, and Parnate. Similar medications, Aldapril. It's used to treat Parkinson's symptoms. What is that?
I think it's a vegetable.
Coke band.
Is it a bird?
Coke band.
At higher doses, it acts like a typical MAOI, and so it needs restrictions. Aldapril, recently available in transdermal patch, IMSAM, and it's actually not the Nardil, Parnate, or Marplan, of course. It's a different configuration. Well,
You've been advised.
she was an advisor. She's in trouble? Oh my gosh. Do I have to sign it?
No, that's just your gift from Susan.
Oh, that's great. Oh, Susan, okay.
Yeah, Dr. Susan.
Susan and I have been.
She
Yep.
put the blue eyes at the bottom.
Oh, does she? Oh, okay. We're talking about,
Yeah.
what was his name? Paul Newman had these amazingly blue eyes. And I said, I've got blue eyes. But she said, his eyes were so blue. Because my eyes are shit blue. Excuse me.
Turquoise blue.
Not very pretty. Obviously not very pretty. Mood stabilizers. We're talking about mood stabilizers now. We're talking about bipolar disorder. Mood stabilizers are used to treat bipolar disorder. Many mood stabilizers are used to treat various seizure disorder types, migraines, chronic pain syndromes, aggression, impulsivity, augmentation of antidepressants and antipsychotics. So we're talking about mood stabilizers here. Now you think we're talking about bipolar disorder, and we are, but we're also talking, if you're talking about somebody that's hyper-aggressive, you're talking about somebody that has migraine headaches, we can treat them with the same medications, with the mood stabilizers, as bizarre as that sounds. So here we are, we're treating somebody with chronic fatigue syndrome, or chronic pain syndrome, excuse me, somebody with ADHD who's overly impulsive. We can treat them with the same stuff, as weird as that sounds. So despite the fact that bipolar disorder is one disease and ADHD is another disease, we can treat them with exactly the same medication and get exactly the same result. Other classes of meds are also used in bipolar treatment, usually in combination with mood stabilizers, treatment of acute mania versus prophylaxis versus depression. We can use this medication for the same stuff. The first mood stabilizer that they came up with was lithium. This gets really weird because they discovered that lithium cures bipolar disorder. It stabilizes their norepinephrine level. Their norepinephrine level is what which is the neurotransmitter that skyrockets to make them act manic. So they discovered that lithium actually brings down their norepinephrine level. This was in 1949, the year I was born. 70 years ago, almost. 70 years ago. So in 1949, lithium was recognized as an anti-manic because it lowered their norepinephrine level. 1949, lithium toxicity identified after being used as a substitute for sodium in salt. So listen, wait a minute, it gets really stupid. They decided that they would start your table salt, they would put lithium in there instead of sodium. Instead of sodium chloride, it would be lithium chloride. And so they would make everybody less aggressive by putting lithium in your salt. And they tried this. And some people died because they put lithium in there and it became toxic. One of the problems that you have with lithium is you have to check it to make sure you haven't built up an excess amount in your system. This is a heavy metal. This is like mercury. This is like, that's the stuff that kills you. This is the stuff that they use for rat poison. Not lithium, of course, but the heavy metals are what they use for rat poison. So they started putting this stuff in the salt. As stupid as that sounds now, they thought that they could control everybody's behavior. There was a lot of really strange things that went on after World War II. There was a lot of social control. They were attempting social control in the United States. And lithium was one of the methods that they thought that they could use. There was an anti-communist movement in the United States. And they went flip crazy. They just went goofy. They decided that they needed to make sure there were just too many people with too many strange ideas and with all this impulsivity and all this aggression, and they wanted to control their behavior. The churches and the really conservative people. So they decided that they would try to control them with lithium. Well, it didn't work. I mean, it was stupid. This is 1949. The Red Scare started in 1949, 1950. If you remember World War II, here we are fighting against those horrible fascist Nazis, but our allies were the communists. Russia was our ally. And then after World War II, of course, the Russians tried to take over more and more territory, so we became paranoid about communists. And so the John Birch Society started, the KKK started kicking in, and communists were all these horrible, horrible people. We decided that, and then the McCarthy era in the 1950s happened. So all of this stuff has to do with, as weird as this sounds, all this has to do with politics. And they tried to treat everybody, they tried to lower people's aggression and impulsivity by giving them lithium, putting it in the salt. So when you bought one of those tubes of Morton salt, instead of having the good stuff in it, it had lithium in it. It was not sodium chloride, it was lithium chloride. As stupid as that sounds. 1966, French researchers demonstrate that valproate's efficacy in treating mania. This was in 1966. Before that, and it's, of course, valproate is an anticonvulsant. So we were using it to treat people with epilepsy. 1978, significant studies demonstrate lithium's efficacy in bipolar disorder. 1980 studies demonstrate effectiveness of carbamazepine with bipolar disorder. Lithium features, the only mood stabilizer without significant anticonvulsive properties. We discovered that if we gave them the same drugs we gave to epileptics, then it controlled their bipolar disorder. But we had to give them two. We couldn't just give them one anticonvulsant. That usually didn't work. We had to give them two mood stabilizers. We either had to give them lithium and carbamazepine or Tegretol, or we had to give them Tegretol and carbamazepine. And that controlled their bipolar disorder. What we're doing here is we're controlling the norepinephrine level. So it was the norepinephrine level that we were trying to manipulate. Up to 70% response rate, which you would think that's not very good. But what we were seeing people that were acting manic who were not bipolar. They either were depressed without any mania or they were manic without any depression. So they weren't really manic depressives. They weren't really people with bipolar disorder. It's like ADHD. A lot of people we treat for ADHD, it doesn't work. And the reason it doesn't work is because they're not really ADHD. ADHD is a condition. They have another problem. They have a problem at home. They have other problems. And the problems don't have anything to do with the fact that they can't control their behavior. Demonstrated effectiveness in reducing suicidality. That was the lithium. So one of the positive things about giving everybody lithium was it reduced the suicide rate. Because suicide has to do with impulsivity. Less effective in rapid cycling in mixed bipolar states. So this is one reason to give them an anticonvulsant. Because the lithium really doesn't make them, rapid cycling has to do with bouncing from mania to depression over and over and over again. Full clinical effect may take up to 1 to 2 months because it's a heavy metal. It has to build up in your system. And we have to build it up in your system and make sure we're not poisoning you, which is not always easy. It's excreted through the kidneys, so we can test it by testing your urine. Minimal liver-mediated drug-drug interactions, so we didn't have to worry about that. Side effects of lithium: fine tremors. So if you were ever around somebody with not bipolar disorder, but are being treated with lithium, they can't control themselves. They've got a slight tremor. As weird as that is. Increased thirst and urination. More severe toxicities include coarse tremors, gait instability, vomiting, diarrhea, and confusion. So some people are more sensitive to lithium than others. These individuals, of course, we treat with the anticonvulsants. Increased risk of toxicity with fluid or salt restriction, hot weather, sweating, use of anti-inflammatory drugs, ACE inhibitors or angiotensin receptor blockers, and diuretics. So if you're on anything else, if you have high blood pressure, you can't take lithium. If you have urinary retention, you can't take lithium because it will make you retain more fluid. And now we got a really serious problem. It may cause kidney and thyroid dysfunction, so regular monitoring of creatinine, BUN, and TSH are necessary. Creatinine and BUN are functions of your kidneys. This is how we check your kidneys. We'll draw your blood and we'll do a BUN and a creatinine. TSH, of course, has to do with, that's thyroid stimulating hormone, has to do with monitoring your thyroid. Females are at much greater risk of lithium-related thyroid dysfunction, and for this reason, females who are bipolar, we don't treat them with lithium. Normally, we don't treat them with lithium. In the beginning, of course, that was the only treatment we had. We saw all of these strange interactions, so we stopped treating females with lithium. It caused all kinds of interesting problems. Another mood stabilizer is carbamazepine or Tegretol. It's an anticonvulsant. It's used in acute mania and bipolar maintenance. It's more effective than lithium in rapid cycling in mixed states. It's less effective in bipolar-related depression. And for this reason, if somebody is bipolar and we're treating them with carbamazepine, we may give them an SSRI to raise or to reduce their depression level. Multiple significant drug-to-drug interactions affecting both other medications, reducing their levels, and other medications affecting it, increasing your carbamazepine level. induces its own metabolism, so it may need to adjust your dose over several weeks. Carbamazepine, but of course carbamazepine was invented as an anticonvulsant, so we're using it with people with epilepsy, and we were used to putting them in the hospital and determining their dosage. Side effects of carbamazepine or Tegretol: nausea, constipation, diarrhea, appetite loss, dizziness, sedation, unsteadiness, and confusion. Benign rashes are very common. Sometimes they can get a rash that becomes infected, catastrophic rash, and it will kill them, strangely enough. It may reduce your sodium level, and this is known as hyponatremia. You can do the same thing by drinking too much water. Just okay. Liver function abnormalities are rare, but it's possible with the carbamazepine. Remember, with the lithium, we had a liver interaction. Toxic metabolite can create problems via valproate, and these are all, phenobarbital, these are all things that we treat people with epilepsy. Those three drugs. Independent of carbamazepine levels can be checked separately, of course. Valproic acid or valproate is another anticonvulsant. We developed it as an anticonvulsant to treat individuals suffering from epilepsy. It can be dosed rapidly to treat acute mania. It's more effective than lithium in rapid cycling in mixed states. It's used by some to treat aggression and impulsivity and other psychiatric disorders. It's approved for migraine prophylaxis. Those of you with migraines. Commonly used at top or above levels stated for seizure control. Some suggest supplementation with carnitine, selenium, and others to reduce side effects. So here we are. Remember, I told you if you drink selenium, or if you take selenium, probably most of the dosage you're going to lose in your urine. That's how you get rid of it. Valproic acid side effects: nausea, weight gain, unsteadiness, hair loss, which is always attractive, and tremors. Liver dysfunction, decreased platelets, thrombocytopenia, pancreatitis, just like with alcohol, polycystic ovary disease suggested by some reports. So valproic acid or valproate is another drug that we try not to give to females because it can cause problems with their ovaries. Ammonia levels can be increased, particularly in those rare individuals with genetic metabolic deficits, which gets really weird. And how in the world do we determine this? We normally don't measure your ammonia level. So what we do is are you ready for this? We smell your urine. If it smells like ammonia, then you've got a problem. I know. It's not like we're going around sniffing everybody's urine. But if somebody has ammonia, I don't know if you've ever smelled bleach or something. You know how strong it smells? Well, the urine smells almost that strong. And evidently it burns coming out. Drug-to-drug interactions by various mechanisms with numerous other anticonvulsants, aspirin, and others. And this is one of the reasons I keep telling you guys that you need to see what's coming out of you. So all of these things that, it was in there and now it's gone, that's fine, but you need to make sure it's okay. If it smells funny, your urine, your feces, then maybe we've got a new problem. Your feces should smell like whatever you've been eating. If you've been eating onions, it should smell like onions. You've been eating cabbage, it should smell like cabbage. But if it's black or if it's white, that means that there's blood in your stool. That's blood. It's broken down blood, is what it is. So you need to look for tarry stools, or you need to look for white stools. If your urine smells funny, your urine isn't really supposed to smell like, well, it smells like whatever you've been eating also. But if it smells like ammonia, you got a problem, and you need to do something about it. And this is the problem. We don't talk about this stuff, so nobody knows that you got to monitor this stuff. If it smells like, if it stinks, if your urine smells like, if it has a negative odor to it, then you may have a urinary tract infection. If it's cloudy, you may have a urinary tract infection. And if you don't get it treated, you could get pelvic inflammatory disease. these are all things that you need to be aware of, anyway. So now you guys are aware of it, nobody else is looking for it. And my problem working in the emergency room, these people would come in with, I mean, they've had this problem for weeks, and now all of a sudden they come into the emergency room and there's not a whole lot we can do with them. So now we're treating a worse disease than we were treating before. So if it smells like ammonia, we got a really serious problem. The newer mood stabilizers, these are the anticonvulsants. Lamotrigine was in 1990s. Lamotrigine was investigated for mood stabilizing properties after patients on it for seizure disorders reported benefits. In other words, they were epileptic and they were starting to feel better when they took their medication. In the 1990s, most newer approved anticonvulsants are investigated for mood stabilizing properties. Lamotrigine was approved for bipolar 1 maintenance. Bipolar 1 is the serious bipolar disorder, the severe bipolar disorder. So we started using the anticonvulsants to treat that. Why don't we stop right here? Might as well. It's about time anyway. I gotta go anyway. I'll see you guys later. I'll try to